it's that chronic polyneuropathy that really becomes incapacitating in some patients. So we have a question over here.
Okay, so this is a minor point for the primary care and general medicine physicians in the audience. I was just wondering in this setting about the utility of doing a fecal occult blood test before referring straight for a colonoscopy. I mean, the patient is obviously symptomatic from anemia, and so the fecal occult blood would not be like a preventative screening. It would be a test for what is the cause of this anemia. And the most likely in a male patient of this age is a GI bleed. So, you know, fecal occult blood tests are cheap and quick, but it's still, you know, it's a small procedure. And just what is the utility of doing a fecal occult blood in this setting rather than referring straight for a colonoscopy?
Well, I agree with you. In this particular patient, I don't think anybody would have taken a negative fecal occult blood test and stopped there. I mean, I think everyone would have seen those values and referred the patient for colonoscopy. So it's quick and easy, and it's part of, when I trained, it was sort of part of the routine physical examination. It's become less commonly used now, and so I think it certainly doesn't add to the cost of caring for the patient, but it's another piece of data that you can get. Any other thoughts about that? So this patient went on to have adjuvant chemotherapy. The standard in the U.S. is FOLFOX currently, and we talked about the difficulties there. And so we have another patient. By the way, any other questions from out there about this patient? So we'll move to our second case, which is a 74-year-old man, this time more comorbid conditions: congestive heart failure, diabetes, mild pre-existing peripheral neuropathy. He was found to have a stage 3 colon cancer. His exam was pretty unremarkable. He had a pretty functional performance status, had normal hematologic parameters with a normal CT scan, and it says patient refuses treatment. You know, and frankly, at age 74, some would argue that that's reasonable, although 74-year-old patients with good health, underlying health, would typically be treated in the U.S. with stage 3 colon cancer. But in a patient that's otherwise ill, it might be a reasonable decision. So the question here is, what do you do with this patient who's had surgically resected stage 3 colon cancer, and how do you follow him? So there are the options, and why don't you go ahead and use your clickers, and we'll see what individuals think about that.
That's great. I think that's too hard.
Okay, so we'll see what the audience thinks. So we have CEAs as the most common choice, all of the above second most common, and I'd be interested to hear what other members of the panel think about this, but I think in this case, in my opinion, it depends on what you would do with a positive finding if you found it. If this man is really, really ill and not highly functional, and if you found a rise in his CEA, or if you found a new lesion on his CT scan, or if you found his liver function studies were abnormal, would you act on that information? And if you're not going to act on that information, then I wouldn't do any of them. But I think that if you think there's a possibility of finding a small oligometastatic lesion, then it might be reasonable to do these things and screen for it. And in fact, the standard of care, according to all the guidelines in patients that have treated and potentially cured colon cancer, is to do annual CT scans and serial CTs or CEAs and all those things. But if this patient's functional capabilities are low enough that you might not consider a surgical resection of a metastatic lesion or something like that, I'm not sure I'd do any of it. So I'd be interested to know what other people on the panel think.
So one of the concerns that I would like to propose with the CEA is that it's not always elevated with metastatic colon cancer. About 20% of the time it'll be normal. So I would propose that may not be the best to follow this patient. But thereafter, I think it's not just a matter of what we would do, but also what the patient would allow us to do. And the other concern there is that someone initially at this stage might say, I don't want anything. But if you confront them and say, look, the only way to keep you alive for 3 more years is to resect that solitary lesion in the liver, they might change their minds. So I think that those all have to be kept in mind, but I think probably I would agree with all of the above. Unless the patient is so troubled that their chance of living, remember, still the #1 cause of death, at least in the US, is coronary artery disease. So if their life expectancy is less than 3 years with their coronary artery disease, then maybe you do nothing.
Any comments or thoughts from the audience?
I agree with that answer because from the surgeon's point of view, the 74 years is not a very old age because we operated. If the diagnosis we up to the 85 or 86 years old, he is the physiologically, the withstanding effects of anesthesia and surgery. But in that case, I agree because he has the CCF in the past. Thanks.
Thank you for those comments. I think you're right. It's more than chronologic age. It's physiologic age and functional capabilities and performance status. And I think all those things play a role in your decision making. I'm not sure what this slide is supposed to be.
That's still supposed to be
maybe our pathologist
colorectal.
can help us. This was maybe just...
Again, you may have to forgive me in the sense that I have all these colorectal cancer, but I'm not a pathologist, so I'm just putting those, and I couldn't figure out which patient was what.
Okay, so let's maybe move to the third patient. Okay, so this
That's the same patient.
Oh, same patient, I'm sorry. Being followed with serial CT and CEAs and gets a colonoscopy annually. By the way, I'm not sure any of us would do a CT scan every 3 months. I would not in my practice. I don't know if you others would or not. I think that's probably too frequent. So now it's 2 years later. And 2 years later, this patient now has weakness and decreased appetite, and you see here some abnormal liver function tests and a CEA that's now remarkably elevated at 293 micrograms per liter, and has a CT PET. Probably doesn't need the PET, but we'll see what the images show. And
That's a PET.
I think what I have a pointer here, but I think what we see
the one on the
is
right. I don't know. Dr.
the
Chandra,
CT shows
can
some
you
sort of heterogeneity of the liver here, and the PET shows focal abnormalities in the parenchyma of the liver. That would be my non-radiologist reading of that. Is that? Oh, we have a diagnostic radiologist in the audience. Would you agree with that, sir?
By looking at these two images now, I don't think this is very diagnostic. By looking the CT scan, only one image there, and the hypodensity, as you mentioned, as you show up to this area, could be any artifact coming from the ribs. So one image is not enough for diagnosis purpose. I cannot comment on this one now.
Okay.
But on the other hand now, if we do the PET scan, we always have 3 orthogonal images, axial, coronal, and sagittal images, so that you can correlate the actual anatomy. Because this is not a fusion PET CT, this is just a PET scan alone. So it is very difficult, in axial images to localize the exact anatomy, where the lesion is. Now, even by looking at this one, I don't know, the level of the section. I saw this little shadow there, triangular shape, which is the liver there, but the intensity of the object is quite homogeneous. So by looking at this one, this liver, I think this is just the normal uptake in the liver. Because by looking at this one, this, I call it a hot spot, hypermetabolic, and this one is an intermediate, and this is a background activity. There's 3 different activities there. So by looking at this one, if I see the activity in the same as a liver, because I don't have the SUV value here mentioned there, that means that standard value uptake is not mentioned here. So if I have a choice to looking these 3 intensity, if it's the any lesion similar to the liver intensity, I will say this is indeterminate. And it is this intensity is a background activity, and this is the hypermetabolic. That is a positive activity there. But by looking at this one, I don't know what these two structures are.
I think those are probably in the renal pelvis, I would guess.
Like this could be a kidney. So I don't know exactly the anatomy, the area of abnormality there.
I think maybe those images weren't perhaps the most convincing.
Right.
But with more images, I'm sure that obviously you rarely get a scan with a single image, right? You get multiple images, so you get multiple opportunities. And one of the lessons I learned about radiology when I was an internal medicine resident back in the 1980s is I would go and look at the most obvious thing, and our radiologist said, no, you've got to look at everything. You can't just look at the most obvious. You have to look at all the images. That's why we take every one of those pictures. So anyway, the conclusion with more than one image was that this did represent metastatic disease in the liver. And the liver biopsy was positive for metastatic disease, wild-type KRAS, and that'll play a role maybe in therapeutic decision-making. And our next slide here is interactive slide. So metastatic colon cancer documented by biopsy. The patient now says, I'm willing to consider therapy. And the question for the audience with the clickers is, which regimen do you think is most reasonable in a man with metastatic adenocarcinoma? Remember, wild-type KRAS.
I think we've got the clicker for them.
So use your clickers, and then we'll get the response, and then we'll turn it to Dr. Smith to discuss that, since he just gave us that talk.
I think that the responses are actually quite correct. If resources are not a problem, I would choose number 1 or number 2, because there is contribution of about 5 to 6 months median improvement in survival with minimal, albeit some added toxicity. But in a climate where, the resources are limited, I think this is not a patient that we're going to cure. So capecitabine is also a very acceptable answer.
May I just make a comment? First of all, I think that to just say multiple bilateral, this could be resectable disease. This patient has been inadequately assessed for resectability. And so I think that's the first step, is to just on a non-contrast PET is woefully inadequate to assess resectability, and then just jump to chemotherapy. I think the whole message, is that we should think about this as a multidisciplinary process in which one needs to fully evaluate. I also think there's no role for a liver biopsy here. KRAS is concordant with the primary tumor, so if you're concerned about wanting to know the RAS status, you can use the primary tumor. This is obvious metastatic disease in the liver with a CEA of 300 and a positive PET scan. There's no role for doing a liver biopsy. So I would suggest first is better cross-sectional imaging to assess resectability. Bilateral disease is not a contraindication. Multiple could be 3, could be 6, it still could be resectable. And that could have a very different, even in a 74-year-old, could have a very different management. So I think the message has to be pretty clear, not just to jump into this, rushing right to chemotherapy.
So you don't consider 74 as an age limit for resectability?
That's right. I mean, it just depends. I'm just saying, though, the message needs to be, it's likely unresectable disease, but we haven't even seen, we just said bilateral, let's move on to chemo. We need to think about going through the steps to exclude resectability before we jump to that conclusion.
So this is what we're talking about. These are actual cases, and these are the cases selected by my, treated by my fellows. So these are the choices that they took. So you now see that Dr. Chody doesn't agree with that. So
Can I make another point, which is that, the sort of assessment of resectability is very important because it influenced the kind of chemotherapy we would give. This patient is borderline resectable. We would be potentially more aggressive, with combination chemotherapy with targeted agents to get the patient, make the patient resectable, versus if we're going down a purely palliative route, where, in a minimally symptomatic patient, we may be going with capecitabine, as a good choice for this patient. So I think that the resectability issue has to be addressed at the beginning, not only because it influenced the choice of chemotherapeutic agents as well.
I think all the points are well taken. It's crucial to have the complete picture before you make therapeutic decisions. And we only showed a representative image there from the CT PET. I have to assume that there was a more thorough evaluation, and it was reasonable to assume that it was unresectable. But I'm assuming that only because of the slides that I'm given. But I agree with your points.
Another thing, would you go with first-line cetuximab in a wild-type patient?
Well, which one? Panitumumab? Oh, no,
Yeah, you said Avastin or. So, Fred, or all of you, you give the option for number one to include an EGF receptor inhibitor first line in let's say it was clearly unresectable patient. Is that common practice to do that?
If it's a resectable patient, we would still use the FOLFOX aggressive. I don't think we would use panitumumab. No.
So the points that were made were very well taken. That's, again, why we always have a group meeting with surgeons, etc. Several oncologists sometimes differing in opinion. If the patient's going to go to resection, you want to avoid Avastin perhaps in the beginning because of the anti-angiogenic effect on surgery. Dr. Chodi's question, there has been a clinical trial that compared in the wild type FOLFOX Avastin or FOLFIRI Avastin versus FOLFOX cetuximab or FOLFIRI cetuximab. And there's been controversy, but the debate is that they're at least equal. And there is one study called the FIRE study that suggests that the cetuximab in the wild type might have a small advantage. And since we can, we use them sequentially. If we use cetuximab first, later on we'll use Avastin, or vice versa. So I think they're both reasonable.
I think we can go to treatment.
Okay, so let's move on to the next slide, unless there are comments from the audience. So the patient receives capecitabine, gets a nice response documented by improvement in the CEA and liver enzymes and doing well on therapy for 4 months. He is seen for follow-up, and I'm assuming that means that these 4 months are off therapy, and is seen for follow-up, asymptomatic, feeling well, and his CEA has risen from 11 up to 69. And so the question with the clickers is, what do we do next? You see the choices there, and we'll see what you all say. So it appears that the majority would repeat the PET-CT as opposed to a CT scan alone, and I'll be interested to hear some discussion about that, because in my mind, in this situation, monitoring metastatic disease, I'm not sure serial PET scans are terribly helpful. Serial CT might give you a better indication of change in tumor size or tumor volume, or to start different chemotherapy, such as panitumumab or cetuximab as single agents. So I'd be interested to hear from the panel or from the audience. These are not quite so clear cut, maybe in this case. Fred?
Any comment?
Any comments from our audience? We have the microphone here, please.
I agree pretty much doing the PET-CT scan rather than doing only the CT scan, because in the latest generation in PET-CT, we're using the diagnostic, normal doses CT. That means that if we order PET-CT, we do, both, fusion PET-CT as well as the diagnosed CT on the same setting without moving the patient there. So by doing that, I got the CT, full dose, the regular CT with all three orthogonal images, like axial, coronal, sagittal. All the images just like exactly the same as the CT scan. Those images I got. In addition, I got the PET. That means that if I see something, a nodule or mass, then I correlate with the PET scan. Well, this nodule or mass is hypermetabolic. So at the same time, in my report, I can tell that, this is the mass is growing, and the SUV. That means that the activity is also rising. So you get, both information, anatomy, anatomic, information, as well as the physiologic, the information by doing the PET-CT.
So I agree. In general, you get a little more information. I'll tell you that in the U.S., for example, Medicare won't pay for serial PET scans. They'll pay for serial CT monitoring over time. And so it depends a little bit on where you practice and what the resources are, but I think you get a bit of additional information with the PET, but I think for monitoring purposes, most of the time we get enough information with PET, or with CT, excuse me. So the patient actually, with the rise in CEA, and it doesn't say whether the imaging was done, I suspect there probably was some imaging, because most of the time we won't start a new regimen without having a new baseline, a new set of images to help guide our assessment of response. And so it started on panitumumab, which is the anti-VEGF drug that we heard about, and so develops a pruritic rash all over the body after one dose. This is just an image indicating the rash. And I can tell you from my practice, this is a relatively mild rash with panitumumab. I don't know how much experience there is in the audience using that agent, but it's typically an acneiform rash, head, face, and upper torso, and it can be, you can have these horrible acneiform pustules. This is a mild to moderate reaction. And so how do you manage the rash? I don't know, this is an interesting question. I don't think we've talked about this, but that's certainly one of the major toxicities of panitumumab. So this is a clicker question. How do you manage this rash? This is the most common response here is option 2, applying the hydrocortisone cream topically plus or minus topical clindamycin. Fred, that's your choice. It's how we would manage it at my clinic, and I would assume that's pretty universal.
I will have a look at this rash. Does it connote any efficacy for the drug, like in alatinib? If you give alatinib and if the patient comes out with a minor rash, it seems it means that it's more efficacious than those patients who do not have rash at all.
So that's an excellent question. In lung cancer, there's a correlation with gemcitabine and erlotinib and the development of a rash and clinical improvement. With these EGFR inhibitors, there appears not to be that correlation, and it appears to be a fairly universal, it's a matter of degree, reaction. Almost everyone seems to get the reaction. That's why, perhaps in relationship to Dr. Chody's earlier question, these EGFR inhibitors are a little bit more difficult to tolerate than the bevacizumab, and there's a slant towards giving bevacizumab more. Particularly, we have to watch out for between cetuximab and panitumumab. Cetuximab is a partial humanized antibody. So you can have severe anaphylactic infusional reactions. You have to be very careful with that. Panitumumab is a totally humanized, it's a totally human monoclonal antibody, so you have less reaction. But Dr. Saul, I don't think that it correlates. I think it's a class effect. Almost everyone will get some rash with these.
So, can I just comment?
In fact, I'll just say, that reminds me, I misspoke. I said VEGF. It is an EGFR inhibitor, not a
Can I just comment? So this patient responded to first-line single-agent capecitabine, and then I guess progressed on single-agent capecitabine, and you went to an EGF receptor inhibitor. Why not go oxaliplatin, FOLFIRI, something, another different cytotoxic than going right to a to panitumumab without even using any of the other combination and not even bevacizumab? Just your thought process and why you went with panitumumab.
I think primarily because of his age.
And he, if I
Yeah,
remember
I think,
correctly, he had
well, I think they have a concern about that.
pre-existing neuropathy, I think, and that was
Yeah.
the reason.
But we
not-
can still use FOLFIRI in a sense. But the thing is, my thinking is that they were concerned about age, so they decided to go less aggressive approach. Because if you look at it, even with the thing, they just give the capecitabine instead of using FOLFOX or FOLFIRI at that time, which was probably better to use then than later on.
You stopped the CAPE and then you got progression, you would just start back on the same agent. You wouldn't add panitumumab, would you? In other words, was the capecitabine stopped when there was progression, or was it progressed while on single agent?
Yeah, no, there was progression while on capecitabine. In metastatic, theoretically, we try not to stop anymore.
So then the question, so with this relatively mild to moderate rash, we've treated it topically, and what do we do now? We've had one infusion of panitumumab, what do we do now? And this is another clicker question. Do we continue it, do we hold it and restart it at a lower dose, or do we stop it completely? Make your choices, please. And I think this is a question of severity in my experience. If it is relatively mild, I simply continue it with topical preparations for the rash. If it is a more severe reaction, and I think that's probably what we were trying to portray here, you hold it until it gets to grade 2 or less, and then resume it, and you can use dose reductions along with the topical measures. And it all depends, in my experience, on the severity as assessed primarily by the patient. Some of them look pretty awful, and the patient seems to be tolerating it well, and sometimes very minor-looking things seem to make people miserable. So I think a lot of it depends on how the patient is tolerating it. So here's another case. I don't know how many more we have. A 41-year-old man admitted with rectal bleeding. I'm sorry? Oh, sure.
If you decide on the patient's reactions, would you stop or do not stop if the patient does not feel uncomfortable at all? The patient has a pretty severe rash, by the way it looks, but the patient does not feel any severe discomfort. Would you stop it or not stop it?
I'll probably hold it to let the rash subside a bit, and then restart it a little bit.
Usually we hold it, we have this grade for the rash, so we hold it until it gets down to grade 1. At that point, restart it again. But if you restart, and if the patient gets that severe rash again, restart at lower dose, and that's when we stop panitumumab. We don't push it anymore.
So Dawn Stefanik is part of our panel, and she's going to talk about some of these factors. Do you want to comment now, Dawn?
No,
she's
that's fine.
Okay. She's fighting jet lag, but so I totally agree.
I think she can discuss it at what her says.
We have done what you guys just said. If we have a mild rash, they'll start the topical creams and things and see how the patient does. And if they're not having any discomfort or anything, they'll continue. But as you said, if it gets worse, I mean, that was very mild to me too. I mean, we've seen people who have the rash on their face that look like they're a teenager with just full-blown acne, I mean, everywhere. And then at times that'll get bad and some of the pustules will open and they'll weep. And then at that time we have to, do the treatment, stop, wait till it subsides, and then we'll go back and reduce the dose usually, and then restart.
So the next case, 41-year-old male with rectal bleeding, so wake up radiation oncologist here, especially jet-lagged ones. He had some nausea and near syncope, and was found to be anemic. He had a colonoscopy showing a large, friable, nearly obstructing tumor in the ascending colon. Okay. All right, so I was wrong on that. Biopsy showed an adenocarcinoma in the ascending colon with a CT of the chest, abdomen, and pelvis demonstrating a sub-centimeter regional lymph node, but no distant metastasis. Here you see the labs. Primarily notice the anemia with a still well-preserved MCV, suggesting that the blood loss was acute. Normal platelet count, and I believe normal liver function studies and normal BU and creatinine. So a laparoscopic assisted hemicolectomy was performed with a loop ileostomy. And here's our pathology.
Again, this is not the right sequence, but please read it.
Well, it's malignant glands, and you can see that they're all very architecturally distorted and abnormal. So in keeping with an adenocarcinoma.
No, it was rectal bleeding. I misspoke. I was assuming by the first sentence that this was going to be a rectal cancer.
Right, that's true.
There you go, it's making assumptions. But anyway, it's an ascending colon lesion. Pathology showed a well to moderately well differentiated adenocarcinoma with lymphovascular perineural invasion invading through the muscularis propria into pericolonic tissue, but not to the serosa, and 7 out of 36 regional nodes were involved. Surgical margins were negative. So this is a stage 3C lesion with the TNM staging that you see there. And the question here is, should microsatellite instability test and DNA mismatch repair enzyme levels be done on that patient? You have two choices. The stage 3, wait, don't hit your clickers just yet. Are we ready, Doug?
It's not working for that question.
Okay. So we'll skip that question. Sorry about that. Well, yeah, maybe a show of hands. And I don't know how commonly this is done here by the pathologists. I know that we heard from Singapore that's done fairly routinely. What is the standard here with MSH testing? It is not done here routinely? Okay. So, and I'm not sure, frankly, I think this is more important in terms of ascertaining whether or not this might be a Lynch syndrome patient, but it's not terribly important in terms of determining therapy.
I voted for no because this MSI stability is more useful in case of stage 2 disease where you decide to give or not to give chemotherapy. Depending on the MSI level, if it is stage 4, if MSI low, you will give chemotherapy, high, you will give.
I think because the patient is 41-year-old.
I think the reason to do it here is not to determine the treatment for this patient, but to determine if this patient might be part of a familial syndrome, and that's the reason to do it in this patient. And so what you see here is that there's 2 that are positive, 2 that are negative, if I read that correctly.
MLH1 is negative, and PMS2 is negative.
And here is the specifics of the testing. Neil, would you like to say anything?
Just to show the PCR findings of what that means.
And so what does that mean? And so this is the question for the clickers, if we can get that to work. So does that affect your choice of therapy? Does it affect other things? So please make your choices. So here is the group response. About 40% said the patient and the family need genetic counseling, and 40% said all the above. I don't know that the genetic testing helped me determine that the patient needed adjuvant chemotherapy. I think the stage of the disease helped me make that decision, but the genetic testing certainly suggests that, or the MSH testing certainly suggests that the patient may be part of a familial kindred that's affected by Lynch syndrome or one of those and need genetic counseling. Neil, would you like to?
No, what I would do is I would take all of the, only because the stage 3, being the stage 3, I'll give adjuvant therapy, and there is a possibility that may be hereditary.
The other point is if this was suspected or known prior to surgery, the other is that this patient that could have benefited by a subtotal colectomy rather than just a right hemicolectomy. Now, saying that a stage 3C, this patient's got a bigger problem than a new cancer 10 years from now, given the high risk of recurrence. But still, that's another take-home point, is that one needs to think about in a young patient initially, to think about that prior to, unless it's an emergency operation, it would have been warranted to consider, even in a young patient without any testing, a subtotal colectomy rather than just a right hemicolectomy.
So, why do you think you want to do subtotal? Will there be a benefit on that one, or you just do hemicolectomy and can't you do colonoscopy and keep follow-up?
No, in the patient, particularly if it's an earlier stage cancer, this patient has it still is going to need probably annual colonoscopy, and so the recommendation is to do, in fact, at least for an earlier stage cancer. Again, it's a very advanced aggressive cancer like this may be different, but generally one would consider a subtotal colectomy and then surveillance with just sigmoidoscopy. You don't need full prep, you don't need sedation and so forth, and so that generally the guidelines would be to do a subtotal colectomy in an HNPCC or Lynch syndrome patient specifically, assuming that's what it is.
Only one more thing I want to add is there are 4 genes involved with HNPCC. Even though the risk of colorectal cancer is about 80%, but the PMS2 has the least penetrance. So if you look at the recent data, the people with PMS2 microsatellite instability, the risk of colorectal cancer is only 20%. So people need to individualize care based on which gene is involved. It's like in past we treat everybody with HNPCC with the same hammer, but I think the risk and incidence is different based on what gene is involved.
We do have split up. We're going to end up in maybe we change that to.
So we have one more case that we'll do, and then I think we're going to break perhaps for lunch. This is a 67-year-old man presenting with diarrhea that's occasionally bloody with a 30-pound weight loss over 4 months' time. Has colonoscopy demonstrating a near obstructing mass 10 centimeters from the anal verge, and a biopsy confirms adenocarcinoma. You see that he is moderately anemic with normal renal function, a CEA that's elevated at 30, with CT scans that are done and not endorectal ultrasound. And here is a picture of his pathology slide.
Well, this looks like just a biopsy because it's all fragmented in smaller piece, and you can see the normal colonic mucosa on the left field, and deep to the colonic mucosa, within where you expect the submucosa to be, are these abnormal glands that are scattered amongst stroma that has got some degree of inflammation. Thanks very much for pointing those malignant glands. You've been paying attention during pathology descriptions.
Here is his CT, a representative image from the CT.
That seems to be okay, I think.
Don't know that we can see much there.
That's supposed to be PET. Not really good, clean one, but I think we just get that.
So the CT is said to show no evidence of metastasis, but does demonstrate some colon wall thickening at the rectosigmoid junction. And so what is the next step? Here we ask your clicker use again. So it appears that over half of you said low anterior resection, about a third said AP resection, and less than 10% said a diverting ostomy. Dr. Chody, would you like to comment?
So was there any staging of the T stage? So no EUS, no pelvic?
No EUS, no.
So the first step would have been something to assess whether this is a intermediate stage. And if that's the case, then you're thinking, and no metastatic, you're thinking of a curative intent paradigm. So you're thinking neoadjuvant chemorads as but here you've got question is the near obstructing. And the question is just because the scope can't go through doesn't mean if the patient was still not emergent, then I don't think a diverting colostomy is necessarily needed. One can just go right to, typically if the bowels are still moving, chemoradiation, and likely you'll get a fairly quick response. More and more now, if you have a totally obstructed patient, we'll go to, who's curable, we'll go to a stent rather than a diverting ostomy. But I think here, assuming you're thinking of a bulky tumor, you're going to be thinking chemoradiation. If I had to choose one of these, that would be number 3. But frankly, none of those I would choose.
And I think in my medical center, more patients would get a diverting ostomy than anything else if they were clinically nearly obstructed. I agree with you. If they're still moving their bowels, they're not nauseated, vomiting. I can't remember if there was nausea here, but if there was not any evidence of a bowel obstruction, then most people would treat them with chemotherapy and radiation therapy, because many times those obstructing symptoms will improve pretty rapidly with the radiation therapy and the infusional 5-FU.
The staging should be done first, which could involve either EUS or pelvic MRI, depending on the expertise available, to define TNM staging. And if it is T3 and above, then the plan would be to do neoadjuvant chemoradiation therapy rather than do any one of the three.
What if it's a country like Myanmar where we don't have EUS? Well, will you consider that enough staging done, or do you still try to figure out how to determine what stage that is?
I think at least use contrast with that that CT had no contrast, so I mean at least a CT with contrast, the cross section of the pelvis will give you at least a clue whether this is something that, I mean, it doesn't sound like it could be a T1 or T2 cancer given the symptoms, so I guess you could go right to neoadjuvant chemoradiation without any further staging, but you definitely need at least a good CT scan here. It's also unusual to have a CEA of 30 with localized disease, so I'd be still already very worried about metastatic disease, and that CT was not a good enough quality to really rule out metastatic disease. So you may also consider, I mean, I'm very anti-PET. I think we over-pushed PET here, but you could make a role for a PET CT here, both to stage for a high CEA and a negative CT scan, and some use it for rectal cancer to stage response, so there could be a role for PET.
And I agree with Mike Choti and Sushi Berry on saying that this patient deserves further staging investigations and determine which state is he or she is in. And in our country, since we haven't got any facility to investigate the exact stage of the disease, they usually end up having surgery like this before complete staging being done. And I, for one, would prefer to have these patients empirically to go for neoadjuvant therapy, seeing the overt clinical stage.
And like one can use the old system. If you do an exam and you can feel the mass, if the mass is fixed, that tells you the patient needs neoadjuvant, irrespective of the endoscopic ultrasound or pelvic MRI shows.
Yeah, so for very many years we didn't have endoscopic ultrasound at my facility, and we would have done the very best CT imaging that we could, and probably diverted this patient if they were symptomatic, and then treated them with radiation therapy and chemotherapy. So he has a diverting colostomy, and what's the next step? I've been sort of getting ahead of myself here. So here are the options for you. Please use your clickers right now. Doug and I are a team. I promise you we don't do this regularly, as you can probably tell.
It'd be nice.
While we're voting, just another comment. Diverting ileostomy would be the preferred operation if you're going to divert, not a diverting colostomy.
So the majority of you all would choose option number 3. In fact, all of you all would choose option number 3. Anybody on the panel disagree with that? Okay, that was the only unanimous vote that we've had so far. And so they do go on to get neoadjuvant capecitabine and radiation therapy before surgery. And I think that's the next case. So let's maybe stop for lunch at this point because of time.
Yeah, we so basically behind time. You know what we can do is done. I think we can get a session after the lunch break. So why don't we have a lunch break at this point? It will be downstairs on the first floor in the Brazili room. Am I right? Ground floor. On the ground floor. Okay. So that will be lunch, and we can resume after the lunch is done. We will have about roughly 40 minutes. No, yeah, 50 minutes or so of lunch time.